Well, welcome everyone. We're going to give it another minute or two just to let everyone come on before we get going. Lot to talk about tonight. I think we should get going. Good evening. I'm Dr. Wendy Golden. I'm an endodontist and head of medical affairs at Son Endo. Welcome to tonight's GentleWave Study Club. Tonight, we plan to cover some objectives. We are going to compare multisonic ultra cleaning and laser activated irrigation to passive ultrasonic activation in necrotic oval canals. We're going to evaluate what's the tissue response and debridement outcomes of conventional versus advanced irrigation techniques using histological analysis. We're going to review irrigation approaches covered in the study. What was the control? Looking at passive activation ultrasonics, sweeps, water lays, and the GentleWave system. We will then discuss clinical implications and relevance to endodontic decision-making. This webinar does include 1.5 CE credits, so let's quickly review that process. One, you must be registered. Your attendance will be recorded via Zoom. In an email, we're going to send you a survey that we would like you to fill out, and then we will send you your CE certificate via email. If there's any questions along the way, please reach out to me or education@sonendo.com. This is going to be an interactive sessions and your questions are encouraged. There's going to be a dedicated Q&A after the presentation. Please enter your questions during the lecture into the chat. You may come off mute and camera to ask your questions during the dedicated time after this lecture. Well, we are very excited to have two excellent voices tonight. One at the forefront of endodontic research and the other translating research into everyday clinical practice. First, we will hear from Dr. Mustafa Gündoğar, who I have had the pleasure of spending the last few days together, and his story is fascinating. Dr. Gündoğar is a graduate of Marmara University, where he received his dental degree in 2005. He attended the endodontic program of graduate study at the Institute of Health Sciences at Marmara University and graduated with a PhD in endodontics in 2011. He is currently working in the Department of Endodontics, Faculty of Dentistry at Medipol University in Turkey as an associate professor since 2020. He has published more than 50 research articles in national and international journals. He is also a social media influencer with a following of over 65,000 on Instagram. We will share his profile with all of you shortly. Tonight, he'll present results from his latest histological study published in April of 2025, comparing the performance of multisonic ultra cleaning, two laser-based systems, ultrasonic activation, and conventional needle irrigation. The study focuses on tissue removal in the apical of 5 millimeters, providing us microscopic insight into how these systems perform under minimal instrumentation. Following his presentation, we will be joined by Dr. Karen Potter, a respected endodontist and owner of San Clemente Endodontics. She brings deep clinical expertise and an everyday endo lens to the research you'll see tonight. She'll walk us through a series of her clinical cases that directly reflect daily anatomical and procedural challenges the endodontist will face. So please join me in welcoming Dr. Gündoğar, or Musti, as his close friends call him, and stay tuned as we move from research to reality with Dr. Potter shortly.
Thank you very much, and thank you I would like to thank you for your kind presentation, and I would like to thank Sun Endo family for inviting me United States and for giving you such a nice webinar. In fact, I have no conflict of interest. I'm just going to share my experiences with the high-tech devices. Uh, so, and I apologize, maybe I can make some mistakes because I have some problems with my throat and I have fever. So I apologize if I make any mistakes. And this is my.
Sure. There's
Okay. Okay.
perfect.
And as Dr. Wendy told you, this is my Instagram account. I'm actively using it, and you can reach me whenever you want if you have any questions about irrigation activation systems. And for the last 5 years, I'm mainly focusing on minimal invasive endodontics and irrigation activation systems. And I'm mainly lecturing around the world and around the Turkey, and I always start my presentations with this great article, in my opinion, white lines or white lines, because for the endodontics we usually focus on shaping procedures, operation procedures, and we share all our cases, but we really don't know how well we disinfect our root canals. So the day we stop looking for radiographic aesthetics and start asking how well did you disinfect, success rates will probably start improving significantly. But as we all know, we are living in the era of Instagram and Facebook dentistry. So over the past decade, maybe more than 20% of the published articles, especially in specialist endodontic journals, were inspired by the dentists and endodontists showing their cases on social media, saying, look how small my access cavity is, and look how I well operated the root canals in spite of having such tiny access cavity. But the fact that we should really know that is the disinfection of the root canals. Every day on social media, I'm getting such messages from the dentists around the world and around the Turkey. Hey, doc, look at my root canal treatment. It seems very well as radiographically, but the patient has still pain. The patient has chronic apical abscess for 1 year later, in spite of having such very well root canal operation. So, where did I make a mistake? What's my mistake? Because, as I mentioned, we are mainly focusing on shaping procedures. But as endodontists, our main aim is to prevent and to heal this apical periodontitis. And when we check the literature, we'll see that it's a very common disease. And the literature says that half of the adult population worldwide have at least one tooth with apical periodontitis. And our most important weapon to prevent and heal these apical lesions is root canal disinfection. And in my opinion, around the world, every endodontist and every GPs are cleaning the coronal and middle part of the root canals very well. But the problem is to clean and disinfect the apical part of the root canal. And a very good study by Secure et al. Showed that bacterial infection occurred in all root apices. The volume of the unfilled apical canal system was significantly associated with the lesion size and possibly with bacterial counts. And in the study, findings illustrate the need to truly disinfect and fill the apical root canal of infected teeth during endodontic therapy. Because we have a major problem inside the root canals called biofilm layer. What's biofilm layer? Biofilm layer is an organized population of microbes encased in a polymeric matrix produced by the microbe that is adhering to a biotic or abiotic surface. And it is a community. And this biofilm community makes a protection against host immune system, antimicrobial agents, and physical forces. So, is it easy to remove biofilm layer, especially from the apical third of the root canal? I'm sorry to inform you that it's really difficult. And the literature shows that it's impossible for you to remove this whole biofilm layer by only shrinkage irrigation, by shaping procedures, or by not giving sufficient energy to your irrigant solutions towards the apical third of the root canal. And I am again sorry to inform you that this biofilm layer is mainly located in the areas that we cannot reach by our instruments, like in isthmuses, lateral canals, apical ramifications. They are mainly located in these areas. And we all know that Walter Hess showed that root canal anatomy is much more complicated than we think. And the literature shows that lateral canal apical ramification is about 75% of the teeth, and it's getting increasing at mandibular molar and maxillary premolar. And now let's look at these very famous virologist Theobald Smith's observations. For a disease to happen, to occur in the body, the number of the viruses or microorganisms should be higher, virulence of the microbes should be higher, and the host resistance should be lower. Now think about what you are doing during root canal treatment. Do you know the virulence of the microbes inside the root canal, or do you giving vitamin C to the patient while you are doing root canal treatment? The only thing that we can fight is the number of the microorganisms inside the root canal. We should reduce it. And the literature shows that if we reduce these microorganisms in a certain number, the apical lesion will start to heal. But we shouldn't forget that we can never sterilize the root canals. Even if we can use high-tech devices, we can never sterilize. We can only disinfect the root canals. So what's the reduction to levels? It's the levels compatible with healing. How much microorganisms should we reduce? Maximum reduction. So, for the chemomechanical preparation, the cleaning and disinfection promotes healing. Shaping procedures only improves filling and improves our irrigation styles. So, what are the key challenges in endodontic treatment? I talked about anatomical and the microbiological key challenges, but apart from these challenges, when we check the literature, a certain amount of the teeth were going through vertical root fractures due to the cuspal fractures or radicular fractures. And the literature shows that. So we have another key challenge, structural integrity. So while we are performing our root canal disinfections, as I read from the literature, we should focus on dentin preservation while we are doing our root canal treatments. So Heraclitus said, change is the only constant. So we should keep on changing procedures and we should adapt changing. So we are moving from endodontic triad to endodontic biad. We are mainly focusing on preparation for cleaning and operation. So where are we now at the endodontics? Minimal mechanical shaping to preserve more dentin, irrigation, not for just the main canal, but also isthmuses, lateral canals, apical ramification, and obturation of not only the main canal, but also isthmuses, lateral canals, and ramifications. And I want to remind you that you can see very well obturated isthmuses, lateral canals, or ramifications on your radiographs. But if you don't disinfect these areas well, it's not important for you how you will obturate these areas. So, I'm asking, do we have to activate irrigation solutions in an effective way? Look, I'm not asking, do we have to activate? Do we have to activate in an effective way? Yes, of course. Because thanks to Zapata's great study, he showed that irrigant delivery and irrigant activation is important for sodium hypochlorite to be effective inside the root canals. And instrumentation can remove a great part of the septic content from the root canal, but no file system will ever disinfect the root canal. It's just like the seen part of the iceberg. We usually focus on the incredible shaping ability of the root canal instruments, but they have always mechanical debridement deficits. We also contaminate hard tissue debris accumulation and excessive cutting of sound dentin. But from my perspective, the mechanical debridement deficit is really very important because, especially in the molars, more than 30 or 70% of the canals remain untouched. And also Haposula et al. Showed that for the C-shaped canals, you can only touch less than 13% of the root canals. Can you imagine that? So what you should do? You should use the power of irrigation. I wish the root canals were round like that. So it will be so easy to clean, shape, and disinfect. But our root canals are in oval shape. When we instrument the root canals, the file is turning over here or turning over here. It's just kissing the apical part of the root canal. Thanks to Haposulos, this great video. Now I want to show you two very famous file systems in the dental market and look how they work at the apical third of the root canal. They shape the coronal and the middle parts very good, but look at the apical part. They are just kissing the apical part. So you have to give energy to your sodium hypochlorite or EDTA to clean these areas. I think every endodontist or every GPs can clean this part of the root canal very well. But what about these parts? The biofilm layer. What should we need to remove this area? We need energy. This is really very important. We need energy. And we need high flow volume. This is really very important to remove biofilm layer, especially from the apical third of the root canals. But what has changed? When we read the great article of Shimon Friedman, we'll see that we have a huge success rates in our endodontic treatment. But what are we doing when the patient comes to our dental office? We are performing our primary endodontic treatment. If we're unsuccessful, we are doing retreatment, later periapical surgery, and later baby extraction. But wouldn't it be great if the primary conventional endodontic treatment would have a highly predictable positive outcome? So, in this way, the technology is really helping endodontics to improve our ways and to improve our root canal treatments. Now, I want to talk about GentleWave in terms of my perspective because I'm not a clinical user of this technology, but I have some chances to make research with this technology. But whenever you go to Europe or when you join an endodontic congress around the world, every endodontist is talking about this technology. How does it work? Do you think it really works? Do you think we should effort so much money to buy this system? Everybody is talking about these systems, but I don't think that nobody can know its benefits if they don't use this technology like Dr. Karen Potter. It was first introduced with GentleWave G3 system. Now we are using GentleWave G4 system. This procedure is multisonic energy. It has negative apical pressure It's heating sodium hypochlorite to body temperature. And most important benefit of this system is minimal instrumentation. Look, I am saying a system. I'm not introducing GentleWave as an irrigation device because, in my opinion, this is not an irrigation device. It is a methodology, a technique, a procedure because we are using minimal invasive instrumentation. Even a glide path file will be enough to finish the whole procedure. And most importantly, we don't need shrinkage irrigation anymore. So in my opinion, this is a revolution in the world. You don't have to use shrinkage irrigation anymore. So I don't name GentleWave an irrigation device. It's a methodology. It's a procedure. And clean flow PI instrument, if you check the literature, you'll see that it's the only innovation that cleans the tooth from the outside of the tooth. There's no innovation, there's no technology like that that cleans the tooth from the outside of the root canals. And again, thanks to Hapasulos, this great slide, even in a root canal shaped until 5004, the vertical flow is great. There is a degassing process. I will talk about it later. And there's a high volume of sodium hypochlorite and EDTA circulation in the root canal walls. So I can say that GentleWave is a game changer in endo world. And thanks to Dr. Wendy and Dr. Kirk, they first introduced this system to me. I had chance to practice with this device on extracted tooth. I really would like to thank again for their huge support to introduce this technology to me. Now, I don't want to talk about the GentleWave procedures like making build-ups to place the PI. You already know. So these are some videos that I took during my visit to Sanendo. I'm just skipping these slides. But I want to share this great case report by Karen Potter, and we tried to write these case reports together. And let me show you these two incredible cases performed by Dr. Karen Potter. Look, even in central incisors with a calcified root, a GentleWave procedure with minimal invasive shaping. Look at this root canal obturation. And Karen, how many months the healing? 6 or 4 months?
It was
6 months later,
at least 6.
yeah, you see the healing, and with CBCT check, you see the great healing. And another interesting case that we published at Endo Practice Us, look at this apical lesion with minimal invasive instrumentation, and 6 months later, you see the healing. This is incredible. In my opinion, GentleWave also promotes fast healing when we compare it with the other irrigation activation procedures. Now, I think 1 year ago, Glenn, San Endo launched GentleWave G4 Pro Control System 1 year ago, I think. And by this way, we are increasing the percentage of the sodium hypochlorite to 5%. And this enables us to do really very effective irrigation activation in necrotic cases. Let me show an interesting case that Dr. Habas sent me to show this in dance case you see here. This case was performed by G4 Pro Control System. The Pro Control System uses 5% of sodium hypochlorite instead of using 3% of sodium hypochlorite. After opening excess cavity, you see PI, and after GentleWave, you see the obturation, and you see the great obturation without any voids. I'm 100% sure that GentleWave cleaned all the root canal systems. So, as Dr. Kirk Curry shared these great slides with me, Endodontics Reimagined. And as I took this slide from Advanced to Michael Rivera, the root canal obturation with GentleWave system are used to be so different that we get used to traditional root canal treatments. So let's talk about the literature about GentleWave. How much do we know about the literature if we check the studies about GentleWave? Up to now, more than 40 studies were published in very important high impacted journals. And the GentleWave system shows really effective. The literature says that GentleWave system effectively canals down to the apex. And also vertical flow generated by the GentleWave system creates negative apical pressure. This is very important for me. Negative apical pressure within the root canal that prevents apical extrusion. I will talk about it in my next slides. Also, the healing success rate for patients with significantly large periapical lesions treated with GentleWave system was close to 100%. And we also see that GentleWave procedure remove multispecies biofilm and smear layer. Also, GentleWave system maintains the integrity of the tooth by preserving more tooth structure. And also, we have many case reports with the outcome of GentleWave, outcome in the complex anatomy treated by GentleWave. Now, I want to give you some information about laser-assisted irrigation before comparing GentleWave and photonous sweeps and biolaser erbium chromium YSGG lasers. Now, if we check the world, there are two lasers, hard tissue lasers, that works well inside the root canal for the activation of the root canal irrigants. One of them is erbium YAG, photonous technology, and the other is erbium chromium YSGG laser, biolase, and H-PROS technology. Now, in laser-assisted irrigation, we have two ways. In one way, especially with erbium chromium YSG laser, we place the fiber tip inside the root canals to activate the sodium hypochlorite and EDTA. But in sweeps technology, we place the fiber tip just in the excess cavity, not inside the root canal. Now, what is the difference between erbium YAG and erbium chromium YSGG lasers in terms of ablation? Now, the spectrums with YSGG and the YAG does not seem so much, but this difference is greater than it appears. For YSGG lasers means lower absorption. This means that you are increasing the thermal effect inside the root canals and you are decreasing the photoacoustic effect. The literature showed that. So, if you place the fiber tip inside the root canals, you have always the risk of ablation of the root canal dentin walls. I'm a research guy. I published many articles with lasers because I don't have GentleWave device in Turkey. And I am mainly working with the devices in my hands at my university. And baby, I published 6 or 7 important articles showing the effectiveness of lasers. This is the last article. Let me show to you. This is the last article comparing the sweeps with passive ultrasonic irrigation in reducing intracanal bacteria and inflammation in the cases of apical periodontitis. This is a clinical study, maybe the first clinical study in the literature. In this study, we showed that if we enlarge the root canals more than 35 or 40, there seems no difference between sweeps and PUE in terms of reducing intracanal bacteria. But if you shape the root canals in a minimal invasive way, the high-tech technology works better than passive ultrasonic irrigation. So, if you want to preserve more dentin structure, and if you want to perform a high-quality disinfection, you need high-tech devices. I really believe in that, and the literature shows that. Sorry. So, effective irrigation is really very important. We have many systems in the world: sonic, ultrasonic, lasers, and multisonics. One of the major irrigation activation systems around the world. So, for small size instrumentation, effective, and in my opinion, most importantly, safe activation, you should choose your side. Now, let's talk about Erbium YSGG, Erbium Yak, and GentleWave in terms of these features, with the lights of scientific evidence. What are the effects on root dentin if you use YSGG, YAG, or GentleWave? The literature shows that GentleWave has no detrimental effects on the root dentin walls. But literature shows that if you place the laser fiber tips, like in YSGG lasers, you have detrimental effects on the root canal dentin wall. What about tissue dissolution? When you compare these three systems, Hapasulo et al. Showed that tissue dissolution is really great if you use GentleWave. It's higher than YAG laser and YSGG laser. What about the removal of materials and tissue from the apical canal? The literature shows that you can even remove, I think, broken file with GentleWave. Or Hapasula et al. Showed that it's near to 100% to remove calcium hydroxide from the root canal walls when you are using GentleWave. And as we all know that it's sometimes impossible to remove calcium hydroxide from the root canal walls by using sonic or ultrasonic activation. But in my opinion, the main difference between these three high-tech devices is apical pressure and the potential for extrusion of sodium hypochlorite. Again, the literature showed that GentleWave has negative apical pressure. But in YSGG or YAG lasers, you don't have negative apical pressure. So if you don't use carefully the laser systems, you have always the risk of apical extrusion. What about the irrigant volume circulating in the apical canal? Thanks God to the degassing process of GentleWave, vertical flow, and the multisonic energy, there is really a great irrigant volume circulating in the apical canal. And if you prefer to use laser systems, you should always refresh the irrigant solutions inside the root canal. So you should always have to use needle irrigation. What about the outcome of the root canal treatment? The literature shows really very good healing rates with the GentleWave. But up to now, I couldn't find any study showing the healing rates with the lasers. So, with erbium chromium YSGG lasers, when we check the literature, there's positive pressure, no sodium hypochlorite circulation. YSGG laser can potentially damage root canal wall, dentin ablation, and the most importantly, instructions for clinical use show variation. There is not a certain instruction how to use erbium chromium YSGG laser. What about erbium yak lasers, sweeps or pips? There is still positive pressure, no negative pressure, no sodium hypochlorite circulation. But the main advantage of the sweeps over erbium chromium VSG or water lace is that the fiber tip is in the pulp chamber. So you don't have the risk of no canal wall ablation. But we again see on the social media that there are always positive user comments. We don't, I don't think that nobody's sharing any extrusion case with lasers or something else. But when we check the literature, GentleWave procedure is the only negative pressure, high energy procedure. The only system to circulate high volumes of sodium hypochlorite via the apical root canal. And GentleWave procedure does not cause damage to canal dentin, saves tooth structure. Excellent. We have excellent in vivo and ex vivo research results. It's a proven clinical record in lower no post abdomens and published peer-reviewed and ongoing in vivo research. Now, I want to share my latest research with you. This is the only article in the literature showing GentleWave Pro Control Systems advantage. As I told you before, the Pro Control, with Pro Control, the sodium hypochlorite is at 5% concentration. Now, in that article, I compared sweeps, biolace, waterlace, GentleWave, and PEU in minimally invasive instrumentation of necrotic oval root canals. This is really very important. We shape the root canals until 2004. So my main aim is to focus on minimal invasive instrumentation. And I want to check if I perform minimal invasive instrumentation, I want to see if I can really disinfect or clean the root canal walls.
How many files did you use?
Just one file.
Okay.
2004. And you can reach the article on the website of Journal of Clinical Medicine. And we got really very good histological sections, especially from the apical third of the root canals. The main part of the root canal that we should really focus on, because we know that apical part is the most important area that we should disinfect. But minimal instrumentation and effective irrigation and safe activation. Now, you can see these images on the article, but I want to show you some other images. Look at GentleWave G4 with Pro Control just at the apical part of the root canal. There is no debris. You see? It's totally clean, incredibly, totally clean. But with laser activated irrigation with sweeps, there are some tissue remnants. With water lace, there are still some tissue remnants. I know, maybe you may ask me, if we obturate the root canals well and untopped this tissue inside the root canal, maybe the tooth will heal again. Yes, you're right about it. But I'm 100% sure that with this procedure, GentleWave, you'll have faster healing. This is important. You'll have fasting healing. And what about ultrasonic activation? We showed that in minimally invasive shaped root canals. Sometimes we are seeing some posts shared on social media. They shape the root canals until 20. The dentist is writing, I used passive ultrasonic activation, very well operated root canals. But when we check the histological slides, the ultrasonic activation has left so much tissue remains inside the root canals when I compare it with GentleWave. So I don't think that ultrasonic activation is working effectively in minimally instrumented, especially in necrotic oval root canals. You see the tissue remains? And I want to show you some really very good images, especially with the complex anatomy. This is the apical part of an oval premolar. Can you imagine this root canal anatomy? How can you clean this root canal with a file? Is it possible? Where will you touch with a file to this anatomy? You should give energy to your sodium hypochlorite to have such clean anatomy. And with GentleWave G4 with Pro Control, you see it's so clean, no tissue remains. But with ultrasonic activation, can you see the tissue remains in the apical part? So, as I mentioned to you, and according to my research, for small size instrumentation, effective activation, but most importantly for safe activation, this is really very important. For safe activation, GentleWave is ahead of the laser systems. I can say that. So, because we don't have clear instructions for, especially for erbium, chromium Y SGG lasers. So, where is the end the world is going through? Where are we now? There are so many new and exciting innovations in the endo world. I want to share some of them with you. As we all know that we are using mini robots for some procedures in the medicine, especially the delivering of drugs to the liver, brain. We are using such tiny robots, as you see. Now the scientists started to try these mini robots inside the root canals. So by controlling these mini robots, you will go through the isthmuses or lateral ramifications with these mini robots. It's really very interesting technology. They have shown this technology in extracted dog's teeth, but we'll see what the future will show in the next years. So thank you very much for listening to me. I think we have enough time, so we can again talk with your questions at the end of the lecture. Now, I think Dr. Karen will share her great cases.
Well, thank
Yes.
you so much. That was fantastic.
Thank you.
And insightful. So we appreciate all the work that you do for the research in endodontics. We are going to shift now to from academic research to everyday endo reality. Joining us next is Dr. Karen Potter, known for her technology-forward, patient-first approach. She'll walk us through her cases. So I'm going to turn it over to you.
Great. Thank you. Well, first of all, that was awesome.
I know.
I loved hearing all of that. It was just great. And I think a lot of us clinicians don't always know where to go. And, one of the things that was poignant to me was that, we all want to be better clinicians, and we want our patients to have success, and we want to have success. And there's so many options out there. And this trend of irrigation over the last 10 years has just skyrocketed. And I think it was about maybe almost 10 years ago that I was first introduced to the GentleWave, because I practiced so close to headquarters, Sun Endo's headquarters. And I remember just sitting in this building as a guest thinking, that sounds too good to be true. And if it sounds too good to be true, it's usually too good to be true. So I didn't move. I just sat on all this information that was presented to me for about 3 years. And finally, I decided that I didn't think I was doing my best work. I knew there was something missing, and I found the GentleWave, and it's been a crazy ride ever since. I love going to work every day, and I love seeing my cases, and I love talking to my patients the evening of the treatment, and it's just fun. So I don't have a ton of time today to present, but I just kind of brought a couple cases. Wendy asked me to show cases that are just very straightforward clinical cases that I've used Pro Control. I think it's been about a little over 6 months that I've been using the 5% Pro Control with my G4 GentleWave unit. So these are all cases from the first month of that, because I was trying to get recalls. I didn't get one recall, but everyone else has a recall. So thank you for having me. I also want to mention, when, Dr. Gündoğar talked about all the benefits of the GentleWave, the one thing that I think was missing from that one slide was the degassing procedure. What makes GentleWave stand separately from everything else is just the fact that we don't have bubbles in our bleach. And that's significant to me, knowing that every extent of the root canal system is getting touched by the bleach. So 3%, now 5%, that bleach is reaching all of those areas. So let's talk a little bit about it. If I can get my slide to advance.
First, we might need your help with slide advancement.
I know. Oh, there we go. Okay.
Okay.
So we all know, and I know he showed Dr. Sir Walter Hess and his teeth. We all know it's hard, right? Our goal is to treat apical periodontitis, you said this beautifully, by removing bacterial biofilm, necrotic pulp tissue, inflamed pulp tissue from this complex system. And historically, we had to open things up to get a needle down there, or we had to medicate because maybe we needed extra mechanism of action to help us kill bacteria. And, now, thankfully, we don't need those things. We don't need to open canals up. We don't need to medicate canals, because we're able to efficiently and effectively do it just through the GentleWave. And, one of the things that's interesting about this is this concept of lift and vertical flow, how the GentleWave is actually pulling all the bad stuff up out of the system and not pushing it in. And the research is overwhelming with negative apical pressure. I've done literally thousands of cases, and I've never had a hypochlorite incident. So I trust this technology to be negative apical pressure. And because of that, when they offered me the opportunity to up my concentration to 5%, there was not even a hesitation for a split second in my mind, because why not increase the concentration, increase the effectiveness, increase the efficiency, and not have even a nanosecond of concern that my patients are going to be at risk. So that said, here's what the new Pro Control looks like. It's got, it's titrating it to 5%. In this moment, it's 5.1. And I'm able to run that cycle confidently that there's not going to be any issues whatsoever. So that said, which cases do I use 5%? All of them. Okay. I love that we can choose, but there's no choice for me anymore. It just automatically goes to 5%. I don't hesitate. My assistants know that's what I want. So I'm going to review 3 quick cases with you. These are very standard run-of-the-mill endodontics, okay? Case 1 is a 44-year-old female. Her chief complaint, I have pain to cold and biting with an occasional dull ache. The history was the pain's been going on for a year after the tooth cracked. They tried to do a crown thinking it was just cracked tooth syndrome, and that did not alleviate the pain. So she came in, and her medical history is unremarkable. She was ready to get rid of the pain. So this is tooth 18. And we can see the crown, the zirconia crown is 1 year old. We see a really deep filling on 20, but our pulp testing revealed that 18, sure enough, was our culprit. And it was diagnosed with symptomatic irreversible pulpitis and symptomatic apical periodontitis. So the interesting thing about this case, and the reason I included it in this lecture is to emphasize the safety of GentleWave is that these root apices are sitting virtually on the inferior alveolar canal. Whenever I see cases like this, I immediately think about my patient's safety, and more so, I don't hesitate and worry about safety of bleach extruding. Instead, I hesitate and am concerned about extruding sealer, because I know that the GentleWave will create complete chemical patency on this case, whether I take a file out the apex or not, which I don't. The GentleWave will clean these canals and I will have patency, which will then allow my sealer, if I'm not careful, to extrude, God forbid, into that canal. So I'm looking at this case from a safety standpoint, not from worrying about extrusion, because I trust that negative apical pressure, but I want to make sure that I don't cause pain and pathology for my patient if I extrude sealer into their IA canal. So the other thing I want to comment on this mesial root system is it's a 2-1-2 mesial root system. So immediately I see there's isthmus there that has, inflamed tissue. And I want to get that out because I want to see success for my patients. So I get working length, I personally instrument to a 20 variable taper. So it's an Avalon Biomed slim shaper file. And after I run the GentleWave, I fill the canals gently and carefully with sealer. And then I place a cone, take my film. These are 2 angled films that you can see that I was very cautious not to place sealer to the apex. And once I see this, I'm okay if my fill is a little short because I know it's clean. But when I sear off and I do down pack because I want to get a solid fill, I get actually sealer a little bit extruded. And of course, that's not my goal. I hoped to have no sealer extruded on this case, but I had it and it was fine because the patient's doing great. And they came back for a 6-month recall, and you can see in the 6-month recall cone beam that isthmus area where it was 2-1-2 is nicely filled, and beautiful intact bone, asymptomatic to percussion, palpation, biting, grinding, all of it. Probings are great, and the patient's very happy. So that's case 1. It's basically a vital case, which, we struggle getting fibrotic tissue out of complex anatomy, but with the GentleWave, I don't stress out about it. Case 2 is a 63-year-old female. She's asymptomatic, but her dentist said she needed her root canal redone. Her root canal was done years ago. The dentist found a problem on the radiograph. This patient has a history of osteoporosis and prior use of bisphosphonates, though she was not currently on a bisphosphonate, and anxiety, and her only medication was Lexapro. So here's what she comes in with. We're looking at number 14. We have an apical lesion that we can see on the cone beam. And I did my diagnostic testing and determined that she has previously treated asymptomatic apical periodontitis. So we're going to retreat this case. And I remove the gutta percha, and then run the GentleWave. Once I've run the GentleWave, I fill my canals with sealer. I place my cones. I have a little overextension of my cone on the mesiobuccal root, so I trim it back. Everything else looks solid, and I'm ready to fill. And this is my final product. Once I complete the case, I always, try to see patients back, especially if there's a large apical lesion. I want to see evidence of healing. I usually do 1 year, but because I wanted to show this case in the lecture, I had her come back at 6 months. And here we have bone growth and development of lamina dura. No, the lesion's not completely healed, but it's darn improved. And that's where I would love to see at 6 months. So I'm optimistic. She's asymptomatic still. We're seeing ossification, especially around that root tip. That other bone will grow back in hopefully over time. All right, case 3. This is a 76-year-old female, and her chief complaint is she's had tenderness to biting for a week and a low-grade mild ache. Her history, the pain started a week ago. She sees a periodontist routinely for periodontal maintenance. Her medical history is glaucoma and high cholesterol, and her medications are 2 eye drops and simvastatin. So this is how she presents, and all my testing revealed that we had pulp necrosis of number 30. And one thing I want to point out on this cone beam, if you look at the distal canal specifically, first of all, both canals have calcification, particularly the mesial. But the distal canal, I can tell one of the canals that had receded quite dramatically towards the middle third of the root. So I could see a very clear distobuccal canal, but the distolingual canal, which I knew was there from the coronal view, really didn't start until quite far down the root. Well, when we talk about GentleWave, like Dr. Gündoğar said, we talk about conservation of dentin. And what's really important in these cases is if I can see that a canal joins apically, I'm not going to trough and search and hack up a root system just for the sake of getting a file in it, when I'm confident that the GentleWave will clean those spaces even in the absence of a file touching. So the way that I approached this case was I found my mesial canals, and I found my distobuccal canal, but I did not trough or search for distolingual. Okay, so this is my sealer and gutta percha cone fit film. There's our little distolingual canal, never touched by a file, never even found the orifice, backfilled with sealer when I put it into the distobuccal canal. And here is our final result. Again, I do not have a recall from this patient, but I'm satisfied, and I'm pretty sure they are, or they would be calling me. They always do. So anyway, those are my 3 quick cases. The takeaways, and I want to leave time for Q&A, obviously, is that any tooth that can receive a platform, which is pretty much any tooth that can be rubber dam isolated, can achieve a successful GentleWave Pro control cycle with 5% bleach, okay? I've treated exclusively with GentleWave for over 6 years, now Pro Control for over 6 months. And any case I can isolate with a rubber dam, I can build a platform on and thus run a GentleWave. The negative apical pressure with the GentleWave ensures the safety of our patients, even with 5%. I don't know why they don't have 6, or you said Dr. Buchanan's using 8. I mean, there's really no limitation on the concentration because it's a safe tool. And then don't hesitate to just grab the PI for all the teeth, every tooth in the mouth. It'll benefit you by making you more efficient. It'll benefit your patients by having less postoperative pain, more conservation of dentin, and they'll feel great and very minimal risk of postoperative flare-up. So your patients and you will benefit in the long run. So that's it. Root canals are fun, baby. Love going to work.
Karen, how long have you been using GentleWave?
Over 6 years.
6 years.
Mhm.
How many patients did you
I
treat?
think it's over 3,000. I work 3 days a week, so I probably don't have the numbers of some of my colleagues.
Asking question, but I really wonder, have you ever lived any extrusion cases? Sodium hypochlorite extrusion?
No. No.
That might fit into one of the questions we just had. Are you still getting patency when you use GentleWave?
So it depends on cases where I put my working length file in and I'm kind of clock turning it down and I beep, hear the beep. Yes, that is technically I've achieved patency with a file just purely because I was getting working length. But if there's a case where I am going down with a file and I hit a brick wall, and I know that means complex anatomy, whether it's just a single bend out that distal root or whether it's a apical delta or whatever it might be, I don't stress out. I make that my working length, and that's where I instrument to.
Great. We have some questions on contraindications. Our IFU lists quite a few, but some people are wondering if you use it on third molars.
So I've done, I mean, a lot of third molars end up being extracted in San Clemente, California. But yes, I've used it on third molars, at least a dozen that I've done over the years. I
Okay.
mean, root canal, I mean, we don't do root canals on wisdom teeth that often, but when we do, I have no hesitation. One thing I like to talk about with the contraindications, and you guys remember that, you know, you have to publish this stuff because there's no research to support it and they can't promise it's safe. It says cover your, you know what, list. But in medicine and dentistry, contraindications are usually relative contraindications. They're not absolute. There's only very few absolute contraindications in dentistry. Nitrous oxide on a pregnant woman, for example. Relative contraindications just require clinical judgment, and you have to make that decision of whether, you know, you think it's safe or not. And so everything on that list, sedation, open apex, maxillary sinus, I've done it all without hesitation.
Awesome. Have you changed any of your instrumentation now that you've upgraded to the 5% new protocol?
No, because I have not. And the reason for that is I only instrument to be able to obturate a case. So I need to get a gutta percha cone in there predictably. And I don't want to be wasting countless minutes chairside struggling to obturate. So I select the smallest file that I feel will allow me to obturate the case with ease. Did I stop sharing? Oh, you need me to. Yes.
Karen, do you have any
Figure that out.
obturation suggestions for when you aren't instrumenting a canal that joins, such as the last case you showed? I do the same, but sometimes find that not the entire canal I didn't instrument is filled with sealer. I get worried about voids being left behind.
Yeah, I mean, if you're not instrumenting, you're taking and you're not putting an actual cone of gutta percha in there, you are taking a risk that there will be some unobturated canal space. I think that's a fair statement. But I would say, who cares? Because it's what you take out, not what you put in, that causes success. So yes, maybe you have a little void, or maybe, I don't know, there's some area that doesn't have sealer in it, but is it clinically significant? And the answer is probably not. Now, if it was in the apical third, or if you felt like it was an easy fix, yeah, pull it out and try again. Dr. Habas, Brian, I think you're on here, has great techniques for obturation. He was lecturing at this event a month or two ago, and he has some great techniques if you want some guidance on obturating small canals.
Karen, can you share your instrumentation protocol from establishing glide path all the way to obturation?
Yeah. So I use a 10 or 8 hand file to get working length. And then I go with a ZS1, which is a slim shaper by Avalon Biomed. I think it's a 15 variable taper to length. I instrument to length unless, like I said, I'm blocked, and then I don't even try. I just stop where the tooth tells me I should stop. And then I do a ZS2, which is a 20 variable taper. It's very minimally flared at the coronal. So I'm really just making space so I can get a gutta percha cone. And I use a True Anatomy by Dentsply gutta percha cone to fill my canals usually, unless I seat it and I can't seat it to length. And then I'll use a fine cone.
Do you take a master cone radiograph?
Yes. With sealer.
Yeah.
That's the only working film I take. Unless I'm like, there's something weird and I need a working length film. But typically sealer and gutta percha, master cone film.
And how do you dry?
After GentleWave?
Mhm.
Oh, I use a micro cannula, like a micro suction tip down each canal. And then I just use paper points. Like a fine, usually because the canals are really small, it has to be a fine width paper point.
All right, another question. I have two G3s. Would you recommend upgrading to the G4 for the 5% hypochlorite? Maybe why did you decide to do that? And have you found that this has made your cases more successful?
So I would recommend investing in the G4, not necessarily because of that 5%, but because it's just more convenient. My staff was so happy when I converted, and that's pretty much why I converted, is there were so many benefits of the G4 as from like a logistical standpoint that it was a no-brainer for me. Especially if you have 2 units, you're probably doing a lot of root canals, so your staff will love you. But as far as the 5%, I don't notice any improvement yet because it's only been 6 months, and I really don't feel like that's a long enough time to start. I mean, I'm just starting to get recalls, so I can't really comment on that.
Have you noticed any post-op pain differences with that at all or anything?
No,
Okay,
just about, I mean, we've never had a lot of post-op pain, so with GentleWave.
okay. Do you use lateral or vertical condensation?
So I place sealer into each canal, and then I place my cone, and then I will sear as far down as I can with a heated plugger. Now, mind you, on these with these slim shapers, that's usually not very far because the orifices are quite small. So it's maybe a couple millimeters, maybe at the most. On a bigger canal, it could go down several millimeters. And then, but either way, I do like to get a little down pack. And Cami, on did a post recently on the discussion forum. If anyone is not on there, you should check it out. It's through the AAE about downpacking, and I do agree with her that it is valuable. I just like to know that I'm getting a little apical and hydraulic pressure of my sealer down the canals and into those complicated anatomical variations. So, and then I backfill with a heated gutta percha just to the orifices. So I guess that's vertical. Long-winded. Sorry.
You being long-winded?
I know, right? Shocking.
No, I appreciate it. So we're probably going to ask people to come off mute and camera. Maybe we can lead with this question. Someone wrote in, I have a GentleWave and a Photona laser. I love them both, but I have certainly noticed more flare-ups and persistent pain with percussion when using the laser. I find myself using the laser less. Is there any evidence that can explain that? None of the laser users seem to be complaining from that.
Of course, because if you are using lasers, you don't have negative apical pressure inside the root canals. You have always the risk of apical extrusion. We are also experiencing this in our patients. We are both using erbium chromium YSGG laser at photono CVIPs. Sometimes when we are using the lasers, we see the bleeding coming from the excess cavity. This shows the extrusion. Really, this shows the extrusion. And the day after the procedure finish, we are calling the patients and they have post-op pain.
Okay.
They have post-op pain. And Chris, is it possible to share my screen? I want to show something.
Yes, just go ahead and share again.
Now, we talked about the having patency or not. Can you see?
Yeah.
Okay.
If you go.
For instance, I don't have sufficient numbers of teeth, but for instance, in this case, I couldn't get patency with the lower premolar. But after GentleWave, you see how the canal is clean. And also this great anatomy I want to share. There is no patency. Can you see the anatomy of lower premolar? It's impossible for me to get patency, but GentleWave.
I'd like to compare, I've kind of established this subdivision of patency.
Yeah.
I now call patency with a file mechanical patency, but GentleWave gives us chemical patency, just because innately it's going to go to the apical foramen.
When I saw this image, I really understand the power of technology. Really. In a minimally instrumented canal, until 15 or 20, such a clean apical third.
Mm-hmm.
This is technology.
It's remarkable.
It's technology.
Do you want to talk about some of the latest research ideas that you're thinking about in the future?
Now, the one reason that I was here is that now I'm focusing on non-instrumentation endo, especially in necrotic or root canals. I want to compare photonosweeps, biolays, and GentleWave without using any files, if it really works or not. We'll see. I have done plenty of teeth. I will take sections. I hope the next EAE, maybe I can show the results.
Wonderful. Someone asked about your study with the two different lasers in GentleWave. What about bacteria inside dentinal tubules? Were you able to histologically look at that?
No, it's difficult to see with the
Okay.
histological sections. The dental tubule penetration will be difficult to show. It's another research, in my opinion.
Sure.
But there are many studies showing the microbial reduction when using GentleWave in the literature.
Right. All right. Should we open it up to questions from all of you? If you want to come off mute and camera, please do. This is an excellent opportunity to talk to two unique individuals.
Okay.
Might have to call on people.
I know, I was gonna say, who's out there?
So
Who am I?
don't make me do that.
Who are my people out there? Let's see, do I recognize anybody?
I know. Let's keep going.
Hi, I have a question. Yeah, Dr. Potter. So, I was just wondering, so, like, I know the is the GentleWave like protocol as written, let's say, like instructions for use, is this still 2004?
It is currently 2004. We are finding most users are going smaller than that, but until we do some, dedicated research to change our protocol, we'll
So-
stick to the IFU.
Yeah, okay. I guess that's my question is that, like, I don't know the follow-up. I know some of the follow-up on the research is maybe about a year. I don't know if there's any longer term follow-up. And then I do know a lot of like lectures and presenters, when you see the protocol, that it's rarely do you see the protocol of as is written on GentleWave's instruction for use. I guess I'm just curious about, like, in terms of, I mean, I guess we don't know until someone does the research to look at those protocols, how that might change based relative to the research, if you know what I mean.
I'd like to comment on that, if you don't mind.
Sure.
Yeah.
So one thing that kind of evolved for me over the last 6 years was when I first got my GentleWave back in 2019, I told myself I'm going to change as little as possible. I just want to like get the learning curve of building the platform and doing all this stuff and just having it be something new and getting the hang of it. And so after a period of time, you're like, it's like shock and awe, right? Of, wow, look what this did. I don't need to remove this much dentin anymore. So then maybe instead of instrumenting to a 25 apically, it's like a 20, or maybe it's a 15. But then you start to think, well, why am I removing all this cervical dentin if I don't need to? So then you move away from a standardized tapered file and you start going into a variable tapered file where you're basically parallel in the cervical part. And, this evolution is a process that each person has to come to themselves, but you want to kind of push the limit and become better and have that growth mindset, because you're seeing these amazing results. So, I love showing, I gave a lecture earlier today to a referring doctor's office, and I love showing what I call side by sides, which are teeth that were traditionally prepped, and then my teeth that I do now. And I love just the dramatic difference between that, that funnily looking, back in the greater taper days, back in the 90s. And now what we're doing, where we have these like essentially parallel canals, or even canals that are, if they're bigger naturally, that, like Mustafa said, like you don't even instrument, you just see what it can do just alone without instrument, like on a anterior, like a kid, I take a broach, I pull out what I can of the pulp, and then I run the GentleWave. I don't even touch the tooth with a rotary instrument. So, to kind of answer that question, the protocol might be this antiquated protocol, or but that's where the research was done, and that's what they know is
Yeah.
safe. Again, it's
Mhm.
sorry, what?
Good.
No, yeah, I was just acknowledging. Yeah. Mhm.
Yep.
Okay. Oh, yeah, essentially, and it's again a CYA. It's just like the contraindications. They have to publish something, right? So
Hmm. And do you find do you always take a pre-op cone beam as well for all the cases? I guess I know that. I think that's also in the instructions for use, right?
absolutely.
Yeah. Hmm.
I take a cone beam on 100% of my patients. And the reason I do that, and I was an early adopter of cone beam. I've been using it since 2009. The reason I do that is I try to treat every patient like I would my mom, and I would not drill into her tooth. You couldn't pay me $1 million to drill into my mom's tooth without a cone beam. But I feel it's that valuable for diagnostic imaging.
Hmm.
Hey,
Okay,
can you
cool.
guys hear me?
Yes, go ahead.
Yeah, so I've been using GentleWave for 6 years and love it. Had to commit because I knew that it was going to give us the opportunity to clean the canals the best that we possibly can. So it was a no-brainer investment for me. The thing that's interesting that I find is that there are a handful of cases that I still have failures with that do not look like they should fail. And I'm wondering if you guys have similar experiences where you have, really good looking obturation, solid tooth, solid restoration, everything looks sealed, no fractures, but apical lesions develop post-operatively that weren't there previously. And I'm scratching my head trying to figure that out and wondering if looking at some of the cross-section images that my new friend Musti shared with us, and how amazingly clean those are, but how difficult it might be to dry. Could it be the result of like residual irrigant fluid? I mean, I'd much rather have residual irrigant than biofilm or tissue, but what are y'all's thoughts or experiences on, cases that look like they should heal and don't?
So I always, if I have a case like this, because it happens, nothing's 100% in life or medicine or dentistry. I always try to remind myself that the host has to come halfway. So I can go halfway, the host has to come the other halfway, and sometimes we have to go back in and try again. It's not often, but sometimes we do. So these cases that you've noticed, have you retreated your own work, and were they successful?
Maybe 50% of the time. That's unfortunately, I don't do a whole lot of, accurate record keeping and, details. I remember long ago, my program director said, you'll have cases that fail. And, I got out of endo school in 2004. He said, don't automatically commit them to extraction. He's like, because there's reasons that you don't know why it doesn't heal. So go back in and retreat the case, for no charge to the patient. And about 50% of the time, it'll get better. And 50% of the time, for reasons you don't understand, it won't. And I feel like that's still pretty accurate today, 20 years down the road. Yeah.
So that's the variable of the host that we don't have control over.
The good news is that the number of cases that I have that do that are very, very small. It's maybe one every month or two, which, in my opinion, is, still a success. I guess it's just that I was kind of hoping that, the GentleWave would eliminate those from happening. And while I do know that I'm cleaning and sealing the canals better now than I ever could before, and I sleep well at night. You know, we still we still have our failures. Even
Yeah,
with
there's,
best
I don't think
intentions.
there's any one silver bullet in the world for,
Yeah.
but I feel you, man.
I feel you too. I talked to so many endodontists that use, you know, no irrigation devices, you know, our competitors, ours, and it's wild that we still focus and drive home on that one case a month and stay up, you know, for days on end on that. So I'm just, you sound like, you're a very experienced, confident endodontist. So I want you to focus on the positivity that you've had with your career, which sounds like has been fruitful.
Yeah, it has been. Thanks.
Yeah.
It was interesting. I guess a little side note to reinforce the hypochlorite accident, you know, fear. I just looked at, you know, my Sonendo portal the other day and realized I'd done like 17,000 cases, and I've had one hypochlorite accident.
Oh my gosh.
Was it with a molar PI or a clean flow?
It was with a molar PI, and what I didn't pay attention to in the CT scan was that he had a retained impacted third molar, you know, that had like still, I guess the losing my terminology, but like the cystic lining around the crown, and the apex of the second molar just happened to touch right into that cystic lining. So it was just like free flow. It wasn't into the sinus, it was around the wisdom tooth. Very rare, very unique, but that's the only case I've ever had, you know, an accident on, and never had one with a clean flow.
So did you just say you've done 17,000 GentleWave cases?
Yeah.
Oh my gosh. Who is this on the phone?
My name's Jeff
Hi, Jeff.
Steinkruger, practice in Charleston, South Carolina.
I love it.
That might be my highest number I've heard.
That's awesome.
I think that's accurate. Now I got to go back and check, make sure I'm not being bombastic. But I mean, you know, we do 6 a day, 4 days a week.
Wow.
Maybe that's not 17. Maybe it's 1,700.
Well, thank you. That's just
That's a big difference.
That's all right. I'm not good at math right now, so we're gonna be okay with that. But you've got a lot of wisdom in you that we would love to pick your brain about after this. So thanks for coming on the call.
Oh, you're welcome. Thank you.
I have a question.
Sure.
Hi, nice to meet you. Great experience on great webinar. I just heard that Dr. Mustafa uses a 2004 file in his cases with GentleWave. But my question is about the pre-flare step. What kind of file do you think it is the best option for pre-flaring?
Still, can you repeat the question?
My instrument
Pre-flaring?
research?
Is that what you're asking about?
Yeah, exactly.
Okay.
No, in our research protocol, we didn't use any pre-flaring files.
You don't need to use it.
Yeah, we just used VDW rotate files, 2 and 204. Okay, no pre-flaring files.
Okay, perfect. Thank you.
You're welcome.
You're not pre-flaring either, are you, Karen? No. Yeah.
No, that's I feel like one of the most impactful things about the benefit of GentleWave is you don't need to create space for the needle, and I don't use a needle, period.
Okay.
Hello. Thank you very much for the presentation. I have a question for you guys.
Sure.
This is Carlos Ochoa from Canada, Saskatchewan. I want to know if either of you have changed a little bit the concept of the working length, and if you're working a little bit shorter of that, of what you used to establish as a working length. That will be the first part of the question. The second part is how much and how often you guys experience bleeding after the procedure, and if there's any techniques that you guys use to control that bleeding before the obturation.
Those are great questions. Are you a current GentleWave user?
I've been using it for a little bit, for a month or so.
Okay, and you're using the Clean Flow?
I'm using the Clean Flow
Okay,
and 5%, and yeah, I didn't have any experience with the G3, so I don't know. Yeah, I don't know how was it before.
great. Karen, I'm gonna.
So I instrument to length unless I can't. And then I instrument to wherever the canal allows me to. And then bleeding, I usually don't have much of an issue. Sometimes if my patient's on a blood thinner, it does bleed more. With Clean Flow, though, I find that the bleeding is minimal, and I usually have no problem drawing the case within just a few moments, like maybe 2 to 3 paper points per canal. After I've suctioned the bulk of the fluid out with a microsuction tip. But when I first started using GentleWave, I instrumented 0.5 to 1 millimeter short of my working length. So, but that was when I had bigger canals, and I would then obturate with a one size smaller cone to make it seat entirely. Once I stopped opening my canals, I just changed my protocol. So now I instrument to length. Again, I have no hesitation to doing that, but I don't think that's the current protocol, but that's what I do. I want my gutta percha to go all the way to length. They're already tiny gutta percha cones, and they're hard to, I just want to make sure my obturation looks good, because it's important that it looks good. Again, like you said, it's not what it doesn't, at the end of the day, the white lies, right? It doesn't make a difference, but it does, you still want your work to look good to your referring doctors, to your insurance companies, to all the people that care, the people that are going to pay you.
Can I chime in on the
what about when
bleeding?
you have a ledge or something like that? Do you keep the same principle of not reaching that working length and then using the irrigation and then trying to fill or flow that sealer into the original canal, or you really try to bypass those ledges when you have a case of a ledge, an apical ledge?
I don't, again, if there's an apical ledge, like if it's an anatomical
or
ledge,
even in a retreatment, for example, even a retreatment previously treated a little bit short.
So usually those retreatments are ledged and the gutta percha only goes to the ledge. I just need to remove the gutta percha because the GentleWave does the rest. So I will just plan to fill that additional space with sealer, and my gutta percha usually goes to sometimes, you can get a file past that point, but usually if it's that ledge, usually not. So I just let the GentleWave do its work. And usually that portion is filled with sealer, not gutta percha per se.
Do you
But
do
it
any
still
attempt
heals.
to pump that sealer? Do you inject it with a more pressure, or do you pump it with the gutta percha point or something like that to make sure?
Yes, there are techniques you can do to improve your hydrodynamic movement of the sealer, pumping or placing the sealer with a little extra pressure if you're not near any critical anatomy, or even taking a little clean hand file and kind of gliding it into that space. If you're able to get, say, a file down there, but not a rotary file, filling it with sealer, and then like Dr. Habas, taking a little hand file and just finessing it into that space, just to make sure that the sealer is moving in that direction.
Thank you very much.
I can chime in on the bleeding issue if you'd like to have another opinion.
Great.
Great. My name's Dave. I've been using the GentleWave for about 8 years. Much of that was with the molar PIs instead of the clean flows. So yeah, there was a period of time where there was a bit of bleeding. And I found that syringing in a little bit of peroxide and letting it soak for 20 seconds, flush it right out, almost all the bleeding stops immediately. Haven't had to use it much in the last 2 years with the clean flow, but it worked great. I know they were talking about iced down saline at first, and that never seemed to work quite as well as the peroxide. So
Thanks, Dave.
Thanks,
Yep.
Dave.
Thank-
Do you think he's getting bleeding because he's staying short with the clean flow?
No. I try to go for working length always. Okay, so
Okay.
that's why I was asking if it was good to modify that working length, maybe 1.5 or 1 millimeter short, but I think it's, yeah, I use laser also. I've been using water laser for a while also, experiencing also bleeding, maybe more bleeding with the laser than with the GentleWave for the negative pressure reason, no? However, big canals and apices that are a little bit wide, I experienced quite a bit of bleeding, even though I've controlled really well that working length, or that's what I think, no?
I have both laser and GentleWave in the office now, and both of my partners tend more toward the laser just because of the efficiency. I'm about to retire. I don't need the efficiency at this point, but I still enjoy my GentleWave, and I use it probably 90% of the time because post-op pain, plain and simple. It just almost never exists in my GentleWave world.
Sure.
It sucks all the bad stuff out.
It sure does.
We are
Hey,
a minute
this
after,
is Jeff.
but
This
okay,
is
go ahead,
again.
Jeff.
I had to chime back in for a point of clarity. I did not do 17,000 cases. I happen to be in a group practice, and my account is on every one of us.
Wow.
But count me in for 5.
I bet
So
you I had
one
to
other,
beat.
one other question that I had was, we're with the GentleWave, we're able to preserve dentin, which is beautiful. I love it. Smaller cases, and amazing looking results, great healing, less post-operative pain. But I also feel like we're, not able to dry the canals as well, and we're getting, we're leaving irrigants and residual stuff in there. Obviously, in cases where you got lateral canal, it's amazing to me that. I guess the question is, do you guys think that there's maybe a better system out there, or maybe a better way to dry the canals, or does it even really matter? I mean, it kind of goes back to what another one of my mentors said. It doesn't matter what you put in, it's what you take out, right? Which has always been the premise for successful endotypes. We got to get them clean. And, even you, Dr. Potter, had said, I don't care if I fill it a little bit short because I know it's clean, but we're still leaving fluid there. Is that
And to
is that
your
is that an
remark,
issue?
I think that fluid is just distilled water, because that's like the last 45 seconds of the cycle is just distilled water. So, I mean, it could be blood. But I don't feel like I have a problem drying my canals. I mean, maybe occasionally if there's like a weird anatomical, really broad isthmus or something, kind of abnormal or atypical, but yeah, I don't know. There's probably, I mean, yes, maybe there should be research on how do we dry canals more efficiently. This is a good problem to have because those canals are clean. So there's, you want to keep fluids better than tissue, right?
Amen. Amen. Thank y'all.
Thanks.
Sure. How about one more question from the crowd?
Great job, Karen. Love your posts on the forum.
Thanks.
Awesome. And making sure everyone follows Musti here. It's just incredible to watch him go around the world lecturing.
I practiced for 2 years in Izmir, Turkey, while I was in the Air Force. So loved it there. Ege University.
Which university?
What university?
Ege in Izmir.
In Izmir. Oh, great.
Yeah.
All right. Well, everyone, thank you for joining us tonight. Just to go over a few things, our next GentleWave Study Club is again on the third Wednesday of every month. Will be July 16th with Dr. Scott Hetz. He always gives a wonderful presentation, so please join us for that. And then our next hands-on course is going to be in September 12th in Charlotte, North Carolina with Dr. Sonia Chopra and her team. You're going to be able to observe, apply, and achieve improvements in practice efficiency and GentleWave profitability. So please sign up for that. You can visit gentlewave.com, reach out to your rep or myself, or education@sonendo.com to sign up. Thank you so much, especially to Musti. He has been very under the weather, and I'm just so proud to have gotten to know you and spend time with you. It was an incredible lecture, and to just an awesome all-around person, Karen Potter. So what a welcome addition you were tonight. Thanks, everybody. Go enjoy your night and have a great happy hour.
Bye.
Bye-bye.
Bye-bye.